Afternoon, everyone. Apologies for the delay. We are having a network challenge with our guest lecture, so we are still helping to connect. We are hoping very soon he will join us, and so maybe for now, for the time's sake, we will continue because he has promised that he is closer to come. May I this time welcome everyone to this session. We are going to be presenting on, or we are going to be looking at the issue of factors that affect prescription of an analgesia, especially factors. Then our lecture is Villa, the anesthetist from Lubombo Referral Hospital. And then we will also have a presentation from our Lubombo regional guest, who will give us a case presentation for today. After that, we will then have a brief session on onboarding concerning our ECHO platform. We are working on migrating to another platform that will help us run the sessions easier, and that will also enable our participants or you colleagues to have access to the materials of any session we have had 24/7. So last week we had a presentation. Our presentation was on assessment of pain for persons with who are non-verbally and cognitively impaired. We were finishing our pain assessment. So we finished pain assessment last week. So to review, you can go to our ECHO-Eswatini YouTube channel to watch our previous sessions that we have had. Another thing that we have is that last week we were looking at we were concluding pain assessment. There are things that we made today emphasize. It was the issue that we need to understand the clinicians that proper pain assessment leads to effective pain treatment. So every person has the right to pain assessment, and every person must be assessed thoroughly and must be managed very well. So I'm happy now that Mr. Villa is joining us. So we also talked about that care and pain assessment must be patient-centered. So, and then we emphasized on documentation during pain assessment. So today, we also had a case last week. The case was for a 45-year-old male patient with Kaposi's sarcoma new to stage. It was presented by Manzini Hospital, government hospital. So in those cases, it was discovered that, or it was presented that the medical intervention that they were providing improved the life of the patient, because they know that were becoming or were improving. But then we also focus on the issue of spiritual, social, and psychological assessment and intervention or care for our patients. So we are also saying that, in short, we're emphasizing that our care must be comprehensive. We mustn't focus on the medicals only. So for today, we have Mr. Villa, who will be taking us through the patient factors that influence pain assessment. What I would request from our participants today is that when we are not given the opportunity to talk, please keep your microphone in the mute stage. And then when you have something to say, you have to raise your hand, or you will be given the chance to talk when the time comes. Or else, if you have something to say, please introduce or write that comment or concern on chat. So for today, I would request that we all write our names on chat If you have two or more people, you will also introduce their names and chat. Then may I take this opportunity and welcome you, Mr. Mvila. You may continue with the didactic session.
Thank you very much, colleagues. I'm sorry for joining you late. You know, technology, it's not something that we are used to. And also here at Steg, it's a rural town. Our network is not that good. I hope to finish this presentation in the required 15, at most 20 minutes. May I take you through the patient factors that influence analgesics prescribing decision making. I am William Mvila, presenting from Lubombo Hospital. The outline of the presentation is as follows. We are going to list the factors and we are going to discuss those factors. I hope we'll be able to cover all of them one by one, and then we'll summarize at the end. So these are some of the factors, which means the list is not exhaustive of some of the factors that influence analgesic prescription. The patient factors, of course. So first of all, we can look at the patient's clinical condition and comorbidities. So when we say clinical condition of the patient, how fit is the patient, or how weak is the patient to withstand the side effects of the drug. So, and then also the patient or family's knowledge and expectation, the educational background, in other words, of the patient and of the relatives who are taking care of the patient. So, and also we are going to look at the past experience with the medication, the patient's past experiment with the medication, and the patient's ease of access to drug therapy. Some patients have insurance cover, what we commonly know here as medical aid. And then the psychosocial issues of patients, drug distribution in the body, that is the body weight of the patient, the age, some fat deposits are on the body. They also have an influence on how much analgesics you can give when you are looking at the patient. So now let's go back to discussing the listed factors. Yes.
Basi manje la kuna sibe mute.
Sorry for that. Yes. Patients' clinical condition and comorbidities.
Mr. Mvila, may you unmute yourself? We can't hear you.
Yes, sir. Okay, thank you. Okay. Where should I start now? So back here on this slide, yes. Epilepsy or risk of seizure, the head injury or alcohol and drug withdrawal, some opioids may increase the risk of seizure. For example, you may want to give pethidine or tramadol, but they have a higher risk and should be avoided if possible. So you would opt for the other opioids and the weak opioids if you have such a patient with you. So respiratory conditions, so we should prescribe opioids with caution in patients with respiratory depression. I know, of course, that we do give, and this is a concern for most healthcare workers, but do not deny the patient the treatment. But of course, you wear the
Sorry, colleagues, I think our guest lecturer has some network challenges and he will bounce back. May we give him a few minutes while we are still tracing him so he can be back? I think the challenge is the network today. Sorry for the inconvenience. Yes. May we give him a few seconds? He's reconnecting and he'll be back. We don't know what is happening. The challenge is the network, I guess, but he's trying to connect again.
That's a dialectic.
You can continue, sir. Unmute yourself and then continue. Unmute. We can't. No, it's frozen. Jesus Christ. Check his students. Okay, colleagues, maybe we can continue from where you will be coming back, and then you will find us on the way. Then we will continue the presentation. I think the network is letting him down. But what he was presenting on, it was the patient clinical condition and comorbidities that we need to consider when we are prescribing an opioid. Then you are saying that some of the drugs may have respiratory side effects. So we need to be very cautious when we are prescribing them. However, we need to be always weigh on the benefits and the side effects, so that we'll weigh and see if it is beneficial, other than to withhold the drugs and not give our patients. Another thing was he was also saying that patient clinical condition and comorbidities is the level of consciousness. You know, we need to know some of the drugs will reduce the level of consciousness, so there's a risk of aspiration. So we need to be very cautious when we prescribe the drugs. Sedatives are not well okay to prescribe when the patient has a risk of aspiration. And then also, you remember, we need to also weigh the issues of benefits and side effects. There also the gastrointestinal issues. We also need to know that some of the drugs may lead to constipation, and sometimes it's very complicated. So when we are prescribing the opioids, you need to also prescribe laxatives. Normally, we say we prescribe dual laxatives, which is a stool softener, stimulants, and stool softener like liquid paraffin or lactose. So we are saying that we need to be very careful on that issue. So other things we need to understand is the issues of drugs having issues of gastric ulcers, especially when we are prescribing diclofenac. You need to be very cautious on those ones, because they may make the situation worse. So instead of worsening the situation, you better withdraw such drugs and withhold them for some other patients. And then another thing he was talking about was the issue of constipation. I've already mentioned it. And then the issue of stomachs. Avoid slow release formulation in patients with ileostomies, and monitor closely for efficacy in patients with colostomies due to reduced absorption of the medication. So we also need to be very cautious on those ones also. So the comorbidities are there. Sometimes even the comorbidities we also include the issues of hypertension and diabetes mellitus. There are drugs that we need to withdraw that are also pain drugs. For example, diclofenac, when there is a pain medication, sometimes the issues of organ failures, you need to be very cautious with that one. Another factor that we need to take into consideration is the patient or family's knowledge and expectations. You know, in short, the knowledge and the goals of care. So what are the families and the patient's goals of care? So we need to also consider those ones. They also help us in prescription. So the knowledge, patients or family members actually ask for specific drugs or which can influence the prescribed decisions. And they are able to describe their pain well, making pain assessment and diagnosis easier for the prescriber. So how they describe their pain is very important. And also the knowledgeable patients tend to know their current medication and doses. So you need to know what the patient has been taking and what they understand. And even their fears and misconceptions, they need to be addressed at that point in time. Another factor is that the patient past experiences with medication. The patient past experience of pain and the use of analgesics may influence their perception of pain. So we need to understand. Some patients will refuse to take certain drugs because they have an experience that is not good, especially with the side effects. So we need to be very cautious with those ones. And many clinical studies of opioid for chronic pain suffer from low compliance rates, with patients discontinuing treatment due to adverse effects or with insufficient pain relief. So they will say this one is not helping, so they will stop taking those drugs. So we need to be very cautious with those ones. So that's why we are also talking about the issues of the analgesics when we are talking about pain medication. And then the other one is the psychosocial issues. In our previous presentation on pain assessment, we introduced the issue that pain shall be holistic or total pain concept. So we also consider the pain-related fear and anxiety may also exert pain-inducing effects by other non-behavioral mechanisms, such as increasing somatosensory amplifications. So catastrophizing has also been shown to be the strongest and most consistent psychological factor associated with pain and dysfunction in samples of persons with chronic pain and primarily presenting problems. So we need to also consider those things when we're prescribing those drugs. Even the high stress from work or personal life anxieties, even when prescribing the drugs, you need to understand because they end up abusing those drugs because of those issues. And then another issue is the comorbid mental health disorders and substance misuse disorders. So you need to know any of those factors or any indicators of drug abuse of patients. So we need to know that patients with these risk factors sometimes are more likely to be prescribed higher doses of opioid and more likely to be prescribed other central effective drugs, including benzodiazepines. So pain might go unrecognized, and patients, and particularly members of racial or ethnic minority groups, women, the elderly person with cognitive impairment, and those with cancer and at end of life can be at risk of inadequate pain treatment. So we need to understand those things, and then we consider them when we are prescribing analgesics. And then also psychosocial issues for patients, inadequate attention to pain in certain patient populations due to cultural attitudes, yeah? And even misconceptions and adherence issues. If patients are not adherent, then if you give them the medication, sometimes it's not working. And then poor communication and fear of addiction and pain is inevitable. These are some times of the issues that patient comes with. So you need to understand and help them to understand when they are prescribing those medication. And then possible solution may be that cognitive behavioral therapy can be described as the gold standard in psychological treatment for individuals with a wide range of pain problems. So we need to look at those options sometimes to solutions of the problem. Another thing we need to understand then is the issue of the drug distribution in the body. How is the drug going to be distributed? It may be affected by many factors, including plasma, tissue, protein binding, body weight, body composition, body fluid spaces. Total body weight mass, muscle mass, and fat composition are the major determinants of drug distribution. And women may differ from men in both of these factors. Higher than usual doses of other things are sometimes required to adequately treat pain in obese patients. So it's very important that we also know and take the BMIs of our patients. And maybe in summary, we can say clinicians are always advised to adjust the individualized care plan and prescription of drugs, including analgesic as necessary. Hence, the need to understand the patient factors that can influence such decisions. People who are under palliative and end-of-life care are entitled to high-quality care whenever they are being cared for. They have the right to express their wishes about where they would like to receive their care, where they would like to die, each in hospices and nursing homes and hospitals or at home. Pain management is one of the priority areas of palliative care. The people providing client care should ask them about their wishes, preferences, and take into account as they work with them to plan their care. They should also support families, carers, and everybody who is involved in the care. So those are the things maybe I can share with you. That was under Mr. Vida's presentation. I'm happy now, I'm seeing him there. I don't know if Mr. Vida, you are there, but I've tried to summarize the presentation. I don't know if you have something to add, then maybe we move to our case presentation.
Thank you very much, Mr. Mahlangu. You presented better than me, of course. I would like to add that, like we know, each patient is unique. So try to find the factors that may hinder you from prescribing the right medication for that particular patient. So let's learn to individualize the plan of care for a patient. Of course, pain assessment, and then we review the pain management as the time goes on as we continue to treat our patient. Thank you very much, colleagues, and sorry for the interruptions, frequent interruptions in the network.
Thank you so much, Mr. Mvrila. I think you will contribute more even in the coming cases our expert for today. We have our case presentation. I don't know if anyone would want to add from the participants or the colleagues before then we can have our case presentation by Mr. Pius. Anyone who can wants to add on patient factors influencing prescription of an analgesic. Anyone who can want to add? Okay.
Hello.
Hello, Sister Felicity.
Yes, good afternoon, team. Thank you for the two presenters. That's good work. It's just to add on the patient's knowledge and family. It is very important to assess because sometimes by the time they come to us, they already know, they've already gone through and do some research about the analgesics. By the time you give them, they've got those doubts and those questions. So we don't have to impress, but we have to stick to the medical explanation to them so that they also will see that no, research on Google and the medicine part there's a difference. I have a case whereby the mother decided no, this daughter should not get morphine, and they've done a lot of research, and yet the patient is feeling a lot of pain. The nurses decided to give the patient, they just say this is for pain. It did not tell it's morphine. After some few days, I had to come and say, still you are not ready for morphine. She said, no, I'm not ready. But then I said, you see, after starting getting this medication with this syringe, you have been relieved and there are no those side effects you are fearing. She said, yeah, I'm okay, I'm relieved. And now Mama, I'm about to tell Mom to go back home. Then we explained that was morphine. So sometimes you have to do the unthinkable because they come knowing a lot of things from the outside. Thank you.
Sister Felicity for the addition. Anyone who may wish to add on this that we may not, and then we give the platform to our case presenter for the case for today. If ever you have something to add, we will also read your comments on chat. You can add them there. For now, may I give this platform to Nes Pumayo from Lubombo to share the case with us. So
good day, ladies and gentlemen. Good day, ladies and gentlemen. My name is Pius Pomwano, Bombo Region Palliative Nurse. I'll be presenting today's case. So my client goes by the name of So I'll be presenting today's case. My client is in the Bombo region He is 74 years old and male. He was diagnosed of prostate cancer at Bhavana Government Hospital and is believed to be at the final stage. So the problem here is the client is overdosing on tramadol. He consumes more than 60 tablets of tramadol per week. The concern here is the client is experiencing more pain than he verbalizes on the numeric pain rating scale. He reports experiencing pain even after having taken tramadol for moderate pain. Holistic assessment, chief complaint. The patient complains of lower abdominal pain, which is visceral, that radiates towards the back on ambulation since a month ago. On assessment, on physical assessment, head, nose, head, eyes, ears, and nose, there was no abnormalities detected. The respirations were normal at 16 breaths per minute. GI system, there was moderate constipation, and there is also occasional gastric reflux. Musculoskeletal system, the patient cannot gently ambulate. When walking, he usually use. He also utilizes a walking stick when walking. Integumentary system was post-intern. Genitourinary system. The patient recently reported urine retention. Significant medical or surgical history. Medical history. The patient is a known hypertensive patient. She reported that he has been on hypertensive drugs since the 1980s. He is currently on HCTs at 25 milligrams. He also reports occasional gastric reflux. He was diagnosed of prostate cancer in 2017 at Bhavana Government Hospital and referred to Hospice alone in 2017. With the prostate cancer, it is believed that it has metastasized to the bones and the lymph nodes. Medications. Relevant past medication. He was on diclofenac, 50 grams of diclofenac. Currently, he is on vitamin B complex, tramadol 50 milligrams, omeprazole 20 milligrams, and bisacodyl 525. Pain assessment. Duration of pain is chronic. Character or description. Pain, the patient says the pain is burning and aching. Numerical pain rating is 6. Periodicity, it's constant. Precipitating factors, it's ambulating. The pain is believed to be worse when the patient is walking around. Relieving factors, lying down or reduced mobility. The pain affects mobility. The effect of current medication, it's partial. Pain evaluation. I've had an encounter with the client. I've visited the client 3 times. So the client was admitted here at Hospice in 2017. So I've only managed to see him 3 times. I started seeing the client in September. So on my 3 visits, the patient has been complaining of lower abdominal pain, which is moderate, which is usually exacerbated by ambulating. And the patient has always been on tramadol. So of late, he has complained that the patient has complained that now the pain is radiating towards the back, towards the coccyx and the spinal cord. Progress following intervention. The patient is now able, despite witnessing the pain, the patient is now able to do light home chores like watering the garden with the hose pipe and walking to and from the shop. Social history and pertinent family history. Work status, the patient is a retired domestic worker. Educational level, secondary. Socio-economic status is low. The patient is married. Lifestyle habits, the patient has alcohol use history. Relevant health conditions in the close family members. The patient's father died of uncontrolled diabetes. Advanced directives. Advanced decision to refuse treatment, no healthcare probes. It's his wife. Mental capacity was assessed and the patient is believed to be stable and well-oriented to place, time and events. The patient has not of late shifted any living way. Review of system, vital signs, the temperature is 36.3 degrees. BP 124/78. Pulse 78 beats per minute. Respiration, it's 17 breaths per minute. The saturations are at 98% cells. Pain score is believed to be 5. Echo functionality score is 2. Symptoms that we assess, the pain is believed to be moderate. There is no dyspnea. There is mild anxiety, no agitation, no depression. There is mild fatigue, no nausea, no anorexia, moderate constipation, no dry mouth, and poor mobility. Further plan. The patient was referred to Stobela Health Center for a medical review since the last one was done in 2017. Cancer might have metastasized to the kidneys and bladder, as the patient recently reported during detention. Hence, I believe there is a need for catheterization. Also, coming to the issue of overdosing the drug, the tramadol, I believe the patient needs to be moved up to morphine, since apparently now the tramadol is no longer working for me, as he also witnesses the tramadol even after having taken the tramadol. Thank you.
Thank you so much, Mr. Pumayo. I hope everyone has heard about the case, but what you are getting here is a patient with the prostate cancer at stage 4, an old man with 74 years old, diagnosed in 2017 and enrolled to palliative care in 2017, and then currently the patient is on tramadol, which is not effectively working for the patient. And then we are seeing a patient that there's a contradictory on what the patient is saying the patient is moderate, but he's taking more of the tramadol. So I don't know what concerns the teams can give or ask or help Mr. Pumayo to better care for this patient. If anyone has something to ask Mr. Pumayo or share with him any support. Anyone to ask Mr. Pumayo or support concerning the patient? Oh, yes, Mr. Villa, you can share that. And then follow suit. Yes.
Thank you very much, Chair. And thank you for the presentation, Mr. Pungayo. It's a very informative presentation. I would like you to remind us of the ECOG score for our patient. And then, but all the same, I would like to add that perhaps sometimes we concentrate on the pharmacological interventions of pain management, like we are now talking about tramadol. So if the patient is able to do some mild exercises on the bed, or if the patient can walk, taking those walks and all that, that also is known to assist in reducing the dose for the patient. Of course, this is a difficult patient, like you are saying, that the patient doesn't give you all the right answers when you ask about how much he's taking and all that, and you believe maybe the patient now enjoys the tramadol. Because it does have that feel good kind of feeling after taking it. But I would like to also add that we should also emphasize on the other means of reducing pain than the pharmacological ones. Thank you.
Mr. Villa, Sister Felicity, I saw your hand was up.
Oh, thank you, Tim. Thank you for the presentation, Mr. Pius. On the pharmacological aspect, I think if the doctor can also try a trial of corticosteroids, which is what we have mainly locally, is the dexamethasone. Since the cancer is like it has already spread, so just to debulk the lesion, the patient will not stay that much long, but they know the doctors how to step in the steroid therapy before moving to the next step of the analgesics, because it's seemingly when the patient is not taking well, we say it's not taking well, is overtaking, which means it doesn't feel the relief. And also to consider other aspects at this age, the body doesn't have that much strength, but her spirit and the emotional and the mentality, they are still strong. So we also like to encourage the spiritual care of this patient and let her accept the stage that now she has to reduce the physical activities because they might worsen the condition. Usually, when the prostate cancer spreads to the back, it's highly likely that he might have a compressed spinal occurrence at any time, which means he might have that severe pain and eventually might not even be able to walk. So now I think we only see the metastasis. We have to start advising with the complications and the life changing. And the importance of maybe rechecking on doing the blood test, because when it metastasizes, renal failure is mostly height likely. I'm not sure whether it can pass the urine or is already on carpet. So when there is renal failure, now the frequency of taking some medications, especially morphine, has to be changed. And some other medication, I think due to these compromised renal functioning. I thank you, Tim.
Thank you so much, Sister Felicity, for the insight. I hope Mr. Pius and the team are also taking the notes on how best they can do it. I don't know if anyone would like to add on how best this patient who is now taking more frequent or consuming a 2-week stock of tramadol into 1 week, how best we can help the patient. There's many that have been said. I don't know, Mr. Pius, have something to comment on the 2 feedbacks.
Thank you very much for the feedback that has been given. I've noted that I should consider non-pharmacological means to relieve pain, and also to consider the use of corticosteroids posed by a physician. Thank you.
Thank you. What we can also learn from these patients is that we really need to sometimes look around, as Mr. Mbula said, maybe he has found pleasure on the drug, but before we even reach it there, we need to ensure that maybe for possible, as Sister President said, the co-analgesic will be used, also combined together with the non-pharmacological therapies, especially now that it affects the backbone and the spine. You will find that maybe there's compression there that makes it, if the opioid is there, it will quick, its effect will quick disappear. So you will need some support. Maybe some times you will need check sponge, the warm compresses. We don't know, but I think another thing is the issue of education, because the patient might be underreporting the pain or sometimes not understanding the issues of mild and moderate, So he needs to also be taken through that education, and also the psychosocial issues shall be ascertained and be assessed, because pain sometimes is exacerbated by stress and anxiety. So you will find that there are other stressors. Looking at the family history, how is it in the family, how are the dynamics in the family? This is a man, how is the support in the house? You will find that such issues maybe will be aggravating the situation. Thank you so much. I don't know if anyone would want to add on how best a patient like this can be. Another thing is the issue that maybe the patient should see the doctor. 27 minutes is a long time just to assess which other organs might be affected by the mastitis, so that we can know how best we can, and we need to inform the prescription decision in terms of medication, because you may find that you will give other medications, yet they are now not beneficial much to the patient in terms of physiological response. So I think also that one would be very beneficial to the patient. I don't know anyone who can want to add in from the team. Then we can move to the other item of the new platform that we are going to use for our sessions. Anyone with something to add? I'm hoping there is none to add. I'm not seeing also hands. Thank you so much, colleagues. We have run a long journey this year, since January. We have been running the sessions. We have covered what is palliative care. We have covered the dealing with ethical dilemmas in palliative care. We have covered communication in palliative care. We have covered a lot of issues. We have now covered issues of pain assessment. We are now embarking on pain management. So may we appreciate that support. We want to step up our sessions so that they become more beneficial for you in terms of accessibility of the resources. In the beginning of today's sessions, we mentioned that we have our YouTube channel, whereby all the sessions we've gone through, they are there. But unfortunately, we find that the resource material, some of us are unable to access. So we have now tried to, within the partnership with our ECHO India team, they will help us to have access to a platform that will enable us, all of us, to have equal access to the resources, to have equal access to the sessions. So in the screens, I'm sharing the page of the sessions. From now on, we will little bit change a bit of how we invite and join the sessions. We normally join the session that one person will join and then we will just follow. But now we are a little bit stepping up. What we are going to do from today, as we usually share the registration link with you, we will also continue likewise. But as of today, we will share with you a registration link to become members of the platform. Meaning, if we talk of Eswatini Hospice and Home Palliative Care Program, so we will be becoming members. So we are saying that today we are introducing it to you. We will share with you the registration link to become a member. What we are trying to do is that after each and every project, so after you've registered, when you save the server, when you save that link, that will, once you have logged in, you've registered, you will appear in this phase. It will be displayed to you once you've registered. Then every time you open and you go to the platform, you will have access to all the sessions that you will have attended or that have been provided by the program. So you will be able to view the details of the programs. So in this series, from this week on the 15th to July to June 2023, we will be doing pain assessment and management. So we will be running different codes. So each series contains relevant topics for each. For example, we haven't yet loaded all of them, but under pain assessment and management, today we're doing factors, but they're not reflected here. But next session will be on the 30th of November, and we'll be doing matching drug class to pain WHO ladder. And then our guest lecturer will be Mr. Vida, but he will get the invitation as our guest lecturer. But what we are going to request is that everyone who wants to be part of the session, we will share the link with you to register to be part of the session, so that when we release invitations, then you will be able to access them. Whenever there's a session, you will come and join here. So when you are joining here, we will request that everyone who wants to participate will register to be a member. So when you are joining the session, we may be a group, but one person to join for us all. When the person is joining, when the time to join, you will find the session saying here, join the session. Then when you click join, it will say you are joining with who. Then it will give you an option to select the members you are with who have registered for that session. So every time there's a session, you will also receive a session invite. So for now, may we request that we will share the registration link to be part of this platform. Then 7 days before the 30th, we will then share with you the session invite for this session. We will then share with you the joining link for this session. So once you are a participant or you've registered to the platform, you will then have an access to get the invites, also to get access to the materials that will be provided in that session at any time. So these are the sessions that we have, and many more will be added. The session will be shared through the platforms we'll be sharing with you, either WhatsApp or email. And also the registration session invite to be part of the platform, you can share it with anyone, it is easier. But for being part of the platform, it will to attend a session that will be offered in the platform, it will be a little bit a challenge to anyone who is not registered. So we are requesting that for each and every session, if you want to be part of it, please register. Even if you know you will be joining together with someone else, we will request you to register for that session. Then the person who will be hosting or who will be able to connect the group will be able to come in and then select the participants for that session who registered, who are part of his team. So all this is to help us all have access. What we are going to do is, at the end of the series, the pain management series, after the pain management and assessment series, then we will release a certificate for all the members who have attended all the sessions and able or who have attended at least 90% of those sessions. Members who have been able to attend those sessions will then release a certificate of acknowledgement of that you as a healthcare worker, you have been able to participate in these sessions, and we are now aware you get a certain knowledge on that code, on that theme. So if it's pain management and assessment, or after June 2023, we will then release a certificate for members who have joined. So that's why it is very important that even if you are joining as a group, ensure that you have registered, one, to be part of the platform, two, you have registered for that session. Even if you are not going to use your gadget to log in, but they registered to attend that session, then the person who will join us together in the group will then select your name and then ensure you are also counted to be part of the team that has joined that session on that day. So in short, we are introducing you to this. I know we will be releasing from today, just after the session, we'll be sharing the link with you, all of you through the email, the WhatsApp contact that we have given with us. Also, if sometimes I know our colleagues like Mr. Damini will receive the invites from our director, she will share the link so you can be able to be registered to be part of the platform. And then in due time, before the session or before the next session to come, we will then release joining link, registration links to those who have registered to be part of the platform. So you can also get the recognition that you've attended. It's all in all trying that we can all be able to improve the service delivery to our clients, and all of us be recognized at the end of each program, or at the end of each theme or topic. We can recognize those who have been able to attend all those sessions. Thank you. I don't know if anyone can have a question on what I'm presenting today. Yes, Sister Felicity.
Yes, sir. Oh, thank you. Yeah, we're going up 2022, I hear. I'd like to know if we're expected to pay any subscription or no.
No, there are no subscription. It's still free of charge. It is still free of charge. We are giving all the didactic sessions for free. You will have access to all the materials for every session that are there in the platform. You will have access to them anytime. Once you are registered to be part of the platform, you will have access to every session. Once you have uploaded, like for the next session, after Mr. Vilas finishes the presentation, we will upload the session data. Even the cases for that will be there. Everything will be shared on the platform so that all of us can have access at any time. And also, after that project or that program, like pain assessment and management is complete, that code is completed, then we'll be able to issue a certificate of saying you have been able to attend sessions that we're talking about the following, or you have been equipped with the knowledge and skill on how best you can do the following. So we'll be able to recognize you. So for every member to have access and get the certificate, she or he must be registered with the platform, one. Number two, must be able to register and attend every session. At least 90% of the session must be attended. Then you'll be able to get a recognition certificate that you're able to understand or to attend, or you have been trained on those issues. I know some colleagues will want to get their CPD points. The attendance will also help us able to sign those CPD books for you, because it will show that you have attended, even if you are not using your guidance, but in a group, but the group member that will be joining with you will assist to log you in if you have registered for that session. So there are two steps. We'll share the registration link with this week. As of today, we kindly request you to click it, register to be part of the platform, then share it with others who want to be part of the platform, because now they will have benefit of joining such sessions. More and more sessions are going to come as years goes. In the platform, you will see all the sessions that will come. We still to load them day by day, so you will be able to choose the one that you want to attend every time now and again. If there is none question, yes, Sister Felicity.
For the last time, sorry, Mahlang.
Yes.
It's a very exciting and happy moment to receive a certificate physical. So with this one, is there any plan or maybe a way we can organize a day, celebration day, whereby we can be receiving this certificate physical?
I don't know. Okay, actually, it's the issue that in palliative in ECHO, we emphasize on moving the knowledge, not the people, but I don't know, it can be arranged. I think the management will look around it, and then if needs be, it will be there. Though it comes with cost when we go for printing those certificates. I don't know, Sister, may I not promise much on that, but I'm sure it's electronically they will be shared. I hope you've got my responses. I'm seeing Mr. David saying we will have a problem. Sometimes we have faculty board meetings. It's a pity, but I'm hoping they may not be every day. So I think the more frequent one would be ascertained. But I believe it cannot be 50% of all the time the sessions are held. So at least most of the sessions you will be able to capture them, and we are hoping you will attend to them, and you will be also recognized for attending those sessions on that topic. So I'm hoping you will be catered for. But if then you are registered to be part of the platform, what is good is that even if I'm registered to attend the session, but I couldn't because of different challenges, but I will have access to the resources. That's what is nice. Once you are part of the platform, and then you have also registered to be part of a certain session, you will also have access to the resources that were there on that session. So at least one way or the other, you will still benefit the information. But also in our YouTube, we will continue to upload the session videos for anyone who will want to follow up on what was discussed during that session. Thank you. I don't know if I'm leaving another one behind. Thank you so much, colleagues. May we report and announce that our next session will be on the 30th of November, but I'm sure by the end of this week or next week, we will all have access to the platform and we will see all coming sessions. And even where there are no sessions, you will know that there's no session. So we will all have access. Most of the communication, you will be able to get it. What I will advise and that once you have registered and then you have access to the link, it's just simple ECHO.org hub. So I would request that you save the joining link for yourself so that you don't struggle when you want to access the platform again. So save the link as a bookmark for yourself. It will help you so much. So it is 30th November. Then the last one for the year will be on the 14th of December. Thank you. May we have a good day. Thank you. That marks at the end of our session. Bye-bye, colleagues.
Okay, bye-bye. Thank you.
Thank you.
Thank you.